Hello, everyone. Thank you for attending today's webinar, Beyond the Basics, Unpacking the CMS Interoperability Rule, presented by InterSystems. I'm Ricardo Castaño, and I'll be moderating this webinar. Our speakers today are Ryan Howells, Principal at Leavitt Partners, and Lynda Rowe, Senior Advisor of Value-Based Markets at InterSystems. You can read their full bios on the left side of your window by selecting the Speakers tab. Just a few technical notes before we begin. This webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please make sure your volume is up. This webinar is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentations with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. Okay, now let's begin. Lynda, please go ahead.
Great. Thank you so much, Ricardo. So let's get going here. I know many of you out there have been working to get ready for the rules being implemented in January. So what Ryan and I are going to do today is we're going to spend some time doing a quick review of the rules, but we're assuming most folks sort of are familiar with that. Discussion of the relevant implementation guides and the current status, because again, as you know, some of the things are still in flight, still going through ballot, and then we're just going to go and do some deep dives into some of those tough questions. I know that Ryan and the CARIN Alliance have been getting, that certainly we have been getting from customers and prospects, and we may not hit it all, but we're certainly going to try to hit on sort of a number of what those topics are. So before we actually get going, and I'll hand it over to Ryan, we just want to see who is on the call today. So if you could complete the poll that should show up for you. We just want to know who's on the webinar today, and as those results come in, give it a few. All right, so, sort of equal share of, health plans, vendors, and then, of course, provider organizations and consultants. So quite a few, and then sort of some that fall in that other bucket. But thank you all, again, for joining us today. So with that, I am going to turn it over to Ryan, who is going to sort of start diving into just the overview of the rules. So, Ryan?
Yeah, thanks, Lynda. I appreciate it, and appreciate the opportunity to chat. Just, again, by introduction, I'm a principal at Leavitt Partners. We convene these multi-sector alliances to try to solve difficult issues in healthcare. We formed the CARIN Alliance about 4.5 years ago to do just that, to try to find ways where we can solve the problem of individual consumers getting access to their health information, and worked with the administration, both in terms of the ONC and CMS, on these final interoperability rules over the last number of years. So we're excited to see it come to fruition. We're also an HL7 Fire Accelerator organization, which we'll talk about, similar to Da Vinci and Gravity and a number of other projects. I think what's really important for this group to understand is that the industry has started to collaborate at a scale we've really never seen before. And we would encourage each of you to get involved in these HL7 Fire Collaborator efforts, these accelerator projects, really valuable work that's going on there in all of the different areas. And it's an opportunity to start to standardize healthcare data exchange in a manner that we've previously not seen before. And so it's a really exciting time to be in healthcare IT. So let's jump into specifically the CMS final rules itself. There's really these two big dates for CMS. One is the effective date of January 2021, which folks know now that there is what's called enforcement discretion that has been has extended the date until July 2021. That just means that CMS is not going to enforce the rule until July of 2021. And in our conversations with payers across the country, it looks like most are going to go live somewhere in between those dates. I think there's a number of them that are going to go live in January, and then others will be closer to that July date. But those opportunities in January 2021 is really the patient access API through FHIR Blue Button, as well as a few other IGs that we'll talk about here, and then also the provider directory API. And then in January 2022, that's when we talk about payer-to-payer data exchange. And this has to do with clinical data exchange, where an individual member can access their clinical data not only from their current payer, but any payer that they have had over the course of the last 5 years. And that payer-to-payer data exchange we'll also talk about in terms of how we actually make that happen at scale. So in terms of the technical standards that CMS actually pointed to in the rule, we are now as an industry, not only on the payer side, but also on the provider side, adopting the Fast Healthcare Interoperability Resources, or FHIR, at scale. And so we have an opportunity for us to really start to collaborate around moving to FHIR version 4.0, release 4.0. The other thing that we're starting to collaborate around for an authentication perspective is both OAuth 2 and the SMART application launch framework. For those who don't know, SMART is something that was developed in the provider side of the house a number of years ago by the folks at Boston Children's and the SMART team that's in Boston. And it's an authentication framework that uses OAuth 2.0 so that all the apps can use a similar way to authenticate users. And essentially what it does is it allows for the individual health plans to use the member username and password from their portal as part of the authentication process to authenticate them into the system. So the app would supply that member username and password, portal username and password, and that would authenticate the individual to be able to access their data. It's really the only way we have right now today to authenticate users across systems is using that portal username and password. But if you don't have a portal username and password, don't fear. We are also advocating for the use of a standalone identity and access management service that could find ways where you can actually be able to authenticate those users using that standalone service, which we'll talk about here shortly. And the rule also talks about OpenID Connect and the importance of implementing OpenID Connect so we can start to federate these identity credentials across systems. And then finally, from a clinical side of the house, we are starting to surround around the U.S. core data interoperability set that ONC has published, and we anticipate adding the industry, as well as I know the federal government is anticipating adding additional data elements to that U.S. core data interoperability set over time, and you'll see that grow in terms of what's required to be sent across different entities. As we talk about the claims and encounter data, this is part of the patient access API. It's one of the 3 APIs that are required under patient access, or the 3 data sets. Let's talk about claims and encounter data. CMS, in their additional guidance that they posted on their website, did recommend the CARIN IG for Blue Button. And the CARIN IG for Blue Button can be found at that link. As you click on that link, there are actually 2 links as part of that. There is the current version link, and then there is the STU1 sequence work in progress link back from December of 2019. We are recommending and strongly suggesting to ignore the December 2019 link and to use the current link wherever possible. We recognize that this is not a published version of the STU1 that is out there. That is going to happen within the next couple of weeks. You'll see that in early November. We are finalizing, dotting all the I's and crossing all the T's on that. But there will be very, very little changes between what you see in that current version and what you will see in the final published version. Just minor, wording changes in certain areas of the narrative, for example. And so you can with confidence use that current version as being the near final version for the published version that's going to be out there within the next couple of weeks. Again, it takes some time to get through the HL7 process. this is just a helpful, we worked with Da Vinci to just come up with a helpful diagram of how all this stuff gets put together, because I think folks are struggling with, what does this all mean? Patient access and provider directory and the different implementation guides that are out there. So we tried to put in really a good slide that just kind of puts that all together in one overall view. There's obviously, and this is what both Da Vinci and CARIN are recommending payers implement for that July 1st date. One is for provider directory, the Da Vinci directory. The PlanNet guide is the one that the industry is actually using and rallying around. For patient access API, there are 3 components to that. There is the Da Vinci formulary implementation guide, which actually is extremely useful when an individual is selecting a plan and wants to know whether or not the drugs that they are currently on is covered under that plan's formulary. So during the plan selection process, during open enrollment, it's a great implementation guide to use. But the challenge is when an individual has actually selected a plan and is already in a coverage type, and it gets prescribed new medications, that implementation guide won't work. So the implementation guide that payers and PBMs are going to use, which I want to be clear, is not required by the CMS rule, but it is an option for payers to use, is the CARIN Real-Time Pharmacy Benefit Check implementation guide. So if you're looking for a complete holistic member experience, certainly from a compliance perspective, you can use the Da Vinci Formulary Implementation Guide for plan selection during open enrollment. And then if you would like to go above and beyond the actual CMS rule, you can use the Real-Time Pharmacy Benefit Check API we've put together working with your PBM so that an individual member can know once they've selected a coverage type whether that new medication is on their formulary and benefit, what their out-of-pocket costs are, what their therapeutic alternatives are, and what their cash price is. And that has been published as an STU1 version right now, so it is available to use. But going back to the middle section here on Patient Access API, in addition to Da Vinci Formulary, the other component of patient access is the Payer Data Exchange, which Lynda's going to go into in more detail here shortly, which allows for an individual member to gain access to their clinical data from their current payer, as well as after 2022 through the Payer-to-Payer Data Exchange. And then finally, what I'll talk about here in more detail is the CARIN IG for Blue Button for both payer and pharmacy data. Think of this as explanation of benefit information, about 120 or so claims data elements associated with this. This is information that they typically get in the portal about how their claim has been processed. And all of that information will go through an OAuth, Smart OAuth request so that the consumer apps can actually have access to that information. These are a whole bunch of links that you can use for the CARIN IG for Blue Button that we won't go into right now, but you will have as part of that. I do want to mention that HL7 is doing doing kind of an implementation event at the end of October next week, I believe it is, where you can just come ask your questions. Your developers can actually ask questions at that event. It's on the HL7 website. CARIN will actually be holding a physical connect-a-thon where you can test the API information in November 18th and 19th. Again, you can reach out to us at CARINalliance.com for more information on that. We'll also post some information on our Confluence page about that coming up, where many of the payers are actually going to be ready to test the end-to-end process in November for those that are going to plan on going live in Q1 of next year. So many opportunities to connect with payers and with third-party apps in a test environment coming up. So let's talk about the CARIN IG for Blue Button a little bit. And when we first started this process, we realized that when you look across different payers have different ways to express their explanation of benefit information. And so what we needed to do is to come up with a common model, the data model that says, look, what is just how do we define really an explanation of benefit and coverage type? What does that look like? And so we came up with what's called the Common Payer Consumer Data Set. These are the core data elements that are associated with how to provide this coverage and explanation of benefit information to an individual consumer that would be hopefully consistent across different payers. We then map that information obviously to the fire resources themselves, and all that information can be found on the Confluent site, on HL7's Confluent site, so that you can get a sense of that. But I did want to make mention of this idea that it was important for us to standardize on a similar common data model across different payers, because of the fact, obviously, different payers have different ways to express that information in their portal and through the paper-based process of sending that information to a consumer. And that's the reason for why we decided to go with this common payer consumer data set that actually is mapped to FHIR. Ultimately, we will be using FHIR. That's what we're going to be using as our core. I just wanted to make sure folks understood why that CPCDS was actually out there. And then I'll turn this over to Lynda for clinical information.
Great. Thanks, Ryan. So again, the first of the 3 patient access APIs was the claims information, and now I'm going to talk about the clinical data. So again, requiring patients' clinical data defined as data that payer maintains, and that's an important distinction, right? That you maintain it, that are included in US EDI version 1 have to be made available. And CMS initially had US FHIR Core IG as the implementation guide, but subsequent to that, through some Q&A that the Da Vinci community did with the CMS folks, it came back and added an additional implementation guide, and either of those will satisfy the patient access API requirement for clinical data. But the important thing is that I think the Da Vinci implementation guide identified some sort of missing things in U.S. Core, especially around data provenance and being able to populate that, given that a payer at times does not know where that information might have come from. So again, just want folks to know that, you know, and again, the U.S. Core is stable. I'm not sure. I think that the Da Vinci payer PDX IG has gone through balloting and should be available. So either of those are good resources for those of you who are still in the process of figuring out your implementation. So again, US CDI, for those of you who weren't familiar with the previous standard, it was the common clinical data set. So for those in the provider world, pretty familiar with this. It was part of meaningful use or promoting interoperability. It was the set of data that needed to be shared. Interestingly enough, though, it was a set of data. So US CDI became a framework that allowed flexibility for ONC to come up and expand what was in that data set. And so actually version 2 is being discussed now. There's some feedback requested by, I believe, next week on US CDI version 2. But version 1 is what you see here. And the big difference for those, again, who were familiar with the common clinical data set is it added some new data elements. So it added clinical notes, so a whole set of different types of notes that you would find, vital signs, some additional demographic information, and then provenance, which I talked about, which is where did that data come from. So being able to allow your members or your patients to know what that source of data was, because again, my guess is that, and I'll talk about this later, that when they see things in those mobile apps that they're not sure about, they're going to want to understand, and you may want to be able to address where that data came from. So for plan coverage and formulary, so this is the third, have to make the formulary information available. And again, the IG is the Da Vinci drug formulary. As Ryan said, the real-time benefit check information is an additional implementation guide, and like he said, it adds some additional value to be able to go back. But these are still being developed. I know that our technical team sits on this work group and has been tracking and following to make sure, as many developers should be, are keeping up with the current set of IGs and where it is in the ballot. And finally, provider directory. Again, I'm not going to read it, but the DaVinci PDX PlanNet guide is pretty much the standard, as Ryan said out there. That one is still going through balloting, so not final, but I know folks are rallying around this and are getting ready for it. And again, these slides will be available, so all these links will be provided to you as one comprehensive set of slides so that you can sort of get your resources in one place. So how are we at InterSystems thinking about this? And again, every vendor out there has a way of approaching it. So we are thinking that all of the data that you need gets brought into sort of what we call our unified care record or our single source of truth, our data foundation. It gets aggregated and normalized and deduplicated. In other words, taking and doing identity management to make sure that all of the information is longitudinal around a single identifier, normalizing that so that everything is normalized into the same set of standards and codes, and then finally deduplication. So again, we know that a lot of health plans may get lab data both from a provider network as a CCDA, but also in an HL7 from a reference lab, and those are often the same. And so being able to duplicate that so that when that data gets shared out, the patient or the member is not seeing, two listings for that same lab data. Exposing that through our Fire Gateway services, and again, for the Patient Access API, referencing the implementation guides that we just discussed, making provider directory available. And we didn't talk a lot about this because the deadline is, but the peer-to-peer exchange, making that clinical data available as a member transitions from one health plan to another. I think an important thing, and folks are probably aware of this, but for the Patient Access API, you have to be a current member of that health plan, right? So you've got to have credentials to be able to get access to that information. Peer-to-peer data exchange, there's a 5-year look back. So you may not have been a member for the past 4 years, 5 years, but can still get that and request that information to be sent to your current payer to be able to, again, create and continue that longitudinal record. So now let's do a deeper dive into some of the rules, because this is, they say the devil is in the details. And it was interesting, before we got on the call, Ryan and I were talking about the fact that a lot of this is new. Most of this is new for the payers and for even the providers who are going to ultimately be implementing at least a subset of this, the Fire-based APIs, and having the mobile apps getting access to clinical data. So this is a journey that sort of everyone's going along. But we've got folks like the CARIN Alliance, like the DaVinci folks, and others who are all working together to try to figure this out, along with folks like us at InterSystems and other vendors in the ecosystem working with payers, implementers, and others to try to figure this out together. And we think that's a really important thing that's happened, is the way that the whole community has convened to try to solve and make sure that everybody is marching forward and is able to meet CMS both requirements and deadlines. So what are the tough topics? And Ryan and I chatted about this, but, clinical data, what counts, what doesn't, and I'll talk a little bit about that. And then, what are the implications if the data that you've got is what I call dirty data, and the data provenance? What happens when member services gets a call? Talking about consent, how do you give members consent, and how does that work with state and federal laws? Because again, there's giving access to your data, but you have to be respectful of HIPAA and making sure that somehow, if you're going to share sensitive information, that somehow an affirmative consent has been gotten from that member. And then there's the application authorization process. How do I give access to my Fire endpoints to app vendors, and how do I know they will keep the data secure and protected? And Ryan's going to give you a whole lot of information, because the CARIN Alliance has been doing a lot of work around this. And then, what claims need to be shared and when does the one business day clock start? And I'm hoping that Ryan will sort of touch on that too, because there's been a lot of questions about that, especially if you've got delegated partners that do some of your claims processing. So when do you have to share clinical data? So you have to share data that maintain. And so let's talk about maintain. And again, this is something you should be discussing or have already discussed with your legal and compliance folks, but it's you have access to the data, you have control over the data, and you have the authority to make the data available through the APIs. So if the data meets that definition of maintain, then and the data are part of your enrollee's record within the time frame, that 5-year time frame, then you have to include it in the API. And if you think about sources of clinical data in health plans today, right, there's sort of clinical data that's derived from a claim, and often before you had access to real clinical data from EHRs and HIEs, that's often where you got information about diagnosis and procedures and things like that. You sometimes get lab results. But you also have a case management system, right? So where you're entering information, whether you're on the phone and having a conversation and entering it in, or you get that through information with a conversation or information that's faxed to you or scanned or sent over from your provider network. And then there's data you might get directly from a provider, health system, or an HIE as a result of HEDIS and risk scoring. So sort of a couple of points there. So I know there was a time period, and Ryan, feel free to jump in on this, where there was this whole question about, well, what if there's clinical data that's part of USCDI that's in a PDF that I get as part of my, HEDIS or STARS reporting? Do I have to share that? And initially, CMS said, well, we need to think about it. We don't think you need to sort of extract the data from the PDF. That doesn't make sense. But what they have said is that if you get the information from a provider, you don't need to share that PDF. However, for payer-to-payer, if you get data such as that from another payer, you then have to be able to forward that information along and store that information on behalf of your member. I don't know, Ryan, if you have anything else you want to sort of talk about with regard to clinical data.
Yeah, I don't know if the link came through in the chat to everybody, but I don't know if folks saw that. But if there is a link out there, if not, we'll get it out to folks. But we have a link on our Confluence site that basically where CARIN asked, and DaVinci also has asked CMS a whole bunch of questions to try to get clarity on a lot of these hard topics that Lynda mentioned. And we posted all of their answers on our Confluence site. And so we'll make sure we have that, get that link in the chat and other places. But to Lynda's point, this question came up recently, it's been coming up about what about all that health risk assessment information that are in the PDFs? And so the answer is from CMS that it has to be discrete data, discrete information that matches to USCDI that are currently stored in your source systems. And what that means is they're not asking individual payers to pull out data elements from health risk assessments that are stored in PDFs or faxes. That's not the intent of the rule. The intent is to provide as much data as possible, but not to go to that extreme. Our understanding is that's like 90% of the work associated with doing this, and that has literally just been in the last few days when they've made that clarification, because they had to go through a process internally to confirm that. But I do want to make folks aware of that. Now, to Lynda's point on payer-to-payer data exchange, if in fact the previous payer has the data stored in a PDF and sends the data to the current payer in a PDF, then that current payer would send it to the member in also a PDF format. The current payer does not need to translate the information from the previous payer from PDF into USCDI API form to send to the member. That is not the intent of the rule. It's not something that CMS is requiring. Basically, what CMS said is for payer-to-payer data exchange post-2022, that the current payer needs to supply that information to the member in the what they call form and format that they received it in. So if they got it in an API, they can send it in an API. If they got it in a PDF, they can send it in a PDF. The goal is just to ensure that the current member with their current payer can aggregate their clinical information from any payer that they've had in the last 5 years. One other clarification quickly, Lynda, since we're on this topic, which is there's always this question about date of service. And this January 1st, 2016 date of service about how, that's the date. And then people go, well, we only have a 5 to 7 year period of time that we actually collected, and then the information goes to tape, and then we, do cold storage, whatever the case may be. We get that. That makes sense. But, and this is going to cause some pain, and may have already caused much pain. CMS has used January 1st, 2016 as a date certain. It's a solid date. So if we're in the year 2030, that means that the current member of the current payer can then request access from their current payer back to 2016. But they can only ask for access to data from a previous payer within the last 5 years. So if we were in whatever it was, the year 2030, then it would always be back to 2025. But if they've been with that current payer all the way back to 2016, so for the last, whatever that was, 14 years, then they can ask data from their current payer back 14 years in arrears if they've been there consistently. That is a really nuanced point that I think people aren't, and so your data retention strategy needs to evolve in some way, shape, or form. I'm assuming nobody probably has data retention strategies past probably a decade. And so you start to kind of think about that in terms of how that information is stored within your current system, because the member does have a right to access all that information back to 2016. So hopefully that's helpful, Lynda.
Yeah, no, super helpful clarification, because again, I know that I participated in the Da Vinci group that was asking questions of CMS, and sort of it was confusing, the distinction between the payer-to-payer versus the patient access APIs and what those timeframes meant. So the other thing, has to do with what does the data look like? So when a member actually gets this data into the API, clearly the third-party app vendors will have some control over how they want to present that data back to the members. But for those of you who have worked with clinical data historically, it's not pretty. A lot of the data comes in, it's sometimes falls not in the data field that you want, or it's missing, or it's incomplete, or it's in a coding system that's not sort of the standard that you might anticipate. And so that can show itself. And like I said previously, it might not be deduplicated. So you might show a member the same lab information, even though it's from the exact same lab draw, but you've got two instances of it in your data set, and you just send those along. So we certainly at InterSystems think that your member experience should be really important. You need to think about how do you clean your data, right? Get that data so that when it gets to that third-party app, it can be presented back in a way that is understandable to member and doesn't make your member services phone ring off the hook. So we think about this whole process where you acquire and validate the data, sort of you unify it into this longitudinal view that's both the clinical and the claims, and obviously to some extent that pharmacy data, and then being able to share that using those FHIR access APIs, but that data being cleaned up, normalized, having a single terminology, which it will have to for US CDI, but it doesn't come in that way. So, making sure you've got the capability to be able to do that, both transformation to FHIR, but also that transformation into the correct terminology format. So we think that's really important, that you also want to think about sort of the cleanliness and the goodness of the data you're sharing with your members. And we know that takes time, and that will come over time. But if you think there are sort of issues with claims data, clinical data is just a magnitude worse in terms of that sort of how unclean that data is. And we've dealt with this for decades with our customers, but wanted to highlight that as well. So at this point, I'm going to turn it back over to Ryan, who's going to dig into some of these other sort of thorny questions.
Yeah, and Lynda, just to pick up on the clinical data piece, one of the things we're hearing payers are considering right now is this idea that, the FHIR release version 2 is actually an API that's in production today for many providers. And so, and then release 4, USCDI, is going to be in production in 2022. So to your point about data cleanliness and structured data, a lot of the payers are saying, well, why don't I just request from my provider community and my provider network that they send me the R2 FHIR API version they have in production today. And so that becomes a little bit easier. And then in 2022, they send me the R4 version that they have. With information blocking the way that it is, there's kind of an opportunity to do that. So there's certainly some opportunities that's available that we've never had before. So we talked about CARIN briefly. I won't go into the detail here. There's about 70 organizations participating in this, including Google and Apple, Microsoft, 7 of the 10 largest payers, a lot of what I would call enablers like InterSystems, for example, that are participating in CARIN. It is an amazing experience to see the industry start to rally together in a meaningful way. Cloud vendors, legacy vendors, interoperability vendors, third-party applications, payers, providers, at a scale we've never seen before, to really do this so that it actually works. We can move to an internet-based economy. We appreciate folks' patience in this. We're developing standards faster than we've ever developed them in the history of this country. And so there's a really great opportunity, I think, to participate in something that's going to really help to transform healthcare. So let's talk about this sticky issues that Lynda mentioned at the outset, which is, the data is moving from a HIPAA-protected environment to let me back up. The data is moving from a HIPAA-protected environment to an FTC-regulated environment. So that's moving between regulatory structures. And so when it moves, this personally identifiable health information moves to an FTC environment, it is governed by FTC policy, which is Section 5A, which basically says do no harm to the consumer. And if the individual third-party app says, I'm going to do nefarious things with the data in their terms and conditions, then as long as they do those nefarious things with the data, then the FTC will not do anything against that app. But if the app violates their specific terms of service or their privacy policy, or if the industry agrees to a common single code of conduct for how that data should be handled, then the FTC can actually come in and be an enforcement mechanism on that. And so we obviously in CARIN said, there's no way that we can have an app community that would be in a position where they would do nefarious things with that data. We need to establish a common set of principles, a key set of principles and best practices for how that data should be handled outside of HIPAA, the HIPAA-regulated environment, which is our CARIN Code of Conduct. So we are asking all of the payers and the data holders to be able to ensure that the individual app that comes and registers with your system attests to or not attest to the Code of Conduct. You cannot prevent an app from connecting if they don't attest to the CARIN Code of Conduct, but you can inform the member that this specific app has not attested to a set of industry best practices. And if you want, put warning signals up there, whatever you'd like to do. But you can't prevent them from connecting. I think that's really important. But the good news is all of them that are connecting are getting on board and attesting to the CARIN Code of Conduct. Many of them are going that second level and getting high trust certified, even though some of them don't need to be. They believe in their heart, and we've spoken to really all of them at this point, and there's only about 60 of them, by the way, there's not thousands, that trust and security and privacy are at the core of their business. And if they lose the trust or security or confidence of the individual member, they've completely lost their business. So many of them are competing on those principles. And so they warmly embrace the Code of Conduct and will quickly tell me how much more they've done to protect the privacy and security of the information. We have other phases of this leading up to what we call this validation phase. Again, this is all volunteer. We're working with companies like ENAC and others, excuse me, where we're going to have an opportunity to validate these apps and specifically certify them. So we can not only they self-attest to them, but we can actually certify the apps themselves, and that'll be coming at some point in early 2021. So what does industry adoption look like of the Code of Conduct? Well, you can go right now to myhealthapplication.com, and you can see a list of the applications that are consumer-facing that have attested to the CARIN code, and the vast majority of them have connected to one of these APIs in production, either clinical or after 2022 payer. And we have worked with these companies for quite some time now, and they are very much willing to do this, all great companies that have been doing that. Now, we again aren't necessarily endorsing the companies themselves. We're just basically saying, look, these are the ones that have actually attested to the CARIN code. We can validate that they've attested to it. We can validate that we've seen a demo of their application itself. And generally, it's consistent with the CARIN principles themselves. Obviously, the individual user are going to have to figure out whether or not the app itself and how they handle their data is consistent with their own preferences, and that's going to be a choice that the member's going to have to make. The CMS Blue Button has incorporated many of the principles that we had in our CARIN Code of Conduct as part of the CMS Blue Button 2.0 practice. The VA Lighthouse, that has an API gateway into all the VA data, has endorsed the CARIN Code of Conduct and says that they are an adopter of it. They've been a phenomenal partner with us from the beginning. And we're also announced earlier this year that we've got a partnership with Care Equality and the recognizing, and in turn, hopefully the RCE, in terms of how this operates within the Care Equality or common agreement, the TEFCA kind of framework. So we're excited. Many of the payers, in fact, all of the major payers are going to be incorporating the Code of Conduct as part of the app registration process itself. So we see this as a digital front door, and I'll just go through this very quickly. There's kind of four primary components to this. I think the first component is what we would like to call is really digital identity, and trying to establish the digital identity itself. And so we have an opportunity where we have the digital identity as being the kind of one of the key factors in helping to ensure that the individual is who they say they are across systems. And what we've recommended to the industry is they need to bifurcate their identity and access management services from their back-end system, because right now many of them are bolted onto their portals, which is going to cause a problem, because when you start to do business-to-business exchange or business-to-consumer exchange, that ability to link those two things, we're going to have a separate way to identify both organizations and individuals. And a separate standalone identity and access management service can do that sits at that front door. Secondly, I know people are building an API gateway to make sure that this data can flow. Third, here in the community of problem solvers, is what we call an app registration utility. You're going to have both B2B apps and B2C apps in that registration utility, and you're going to have to find a way to be able to register them. And eventually, we're going to have a very automated process for doing that in a trusted way that we're working on as we speak. And then finally, consumer consent-driven ways to share this information is going to become the norm. It's not an exception anymore. And so with HIPAA authorization, you give consent was related to treatment, payment, and operations, and then the data goes all kinds of different places. But in this new ecosystem, you're going to see that those who are going to really have a competitive advantage are those that are going to ensure that the individual member and their specific consent preferences are ones that are actually adopted by the organization and by the app as to how they want their data to be shared. Similar to the experience you have in the consumer world, where, for example, Apple asks you, are you sure you want to share this data with XYZ? And we're going to see that more and more happening, not only in the FTC space, but I think you'll also see it on a volunteer basis in the HIPAA space as well. We have a set of best practices for app registration. I know we don't have a lot of time to go through this right now, but there are examples out there about building a developer portal and sandbox that are links. We talked about the CARIN Code of Conduct. There's this idea that Epic's done a really good job, and others have as well, about educational materials for the patient. making sure that you kind of register the apps once and then make sure they have availability and access to all the FHIR endpoints that you have, and make sure there's as few FHIR endpoints as possible to get access to the data. You may have 70 systems on the back end. The app doesn't necessarily care that's acting on behalf of the consumer. They just want one. And that's going to help you as well to just have and manage one going forward. But again, we recognize some may have to have multiple depending on what type of access you're granting, whether it's B2B or B2C. We also are working on kind of an advanced way to be able to automate the process of app registration. We have an open standard out there called UDAP that actually is making the way around and finding ways where that can be adopted at scale. We have a Google Doc out there that kind of outlines how that would occur. In the implementation guide, we say it's a May situation where individual health plans may implement UDAP, but you can get a sense in the Google Doc that's linked there about what that looks like. And then we also want folks to increase their security and specifically their authentication protocols. There's a protocol out there called FIDO2, which is a W3C standard, a WebAuthn, that actually eliminates completely the need for usernames and passwords. It's on-device authentication, which is actually been adopted by every major platform, iOS, Android, and Microsoft in the world. And so it's ubiquitous now. The question is, how do payers actually integrate that authentication protocol into how they authenticate users? And SMART has a way to actually integrate FIDO into what's happening. Identity, we don't have a ton of time to go into this, but just to let you know, we are working on digital identity. We had a summit with ONC and CMS last summer where we talked about this idea of identity and authentication and trust and consent and matching. Oftentimes in healthcare, we start with matching and say, how do we match these, two disparate sets of demographic information together? And that is a symptom of the core problem. And the core problem is we don't have a single source of truth that the member actually provides and has been identity proofed. Similar to the physical world, where you have a driver's license. What is our digital driver's license that we can use as being the single source of truth? That doesn't mean we need a national patient identifier. It'd be great if we had one, but doesn't mean we need one. There are vendors out there now that can actually provide you an identity-proof digital credential meeting that NIST guidelines. And our recommendation to the industry is, how do you figure out ways where you can be able to adopt those NIST, those IL2 digital identity-proof credentials, and so you through your standalone identity and access management service, and that starts to simplify the problem of matching across multiple systems. This is some of the work we're doing related to that. Again, don't have a lot of time to go into it, but there are identity providers, there are relying parties, there are trust framework organizations that certify those identity providers. And within CARIN, we have convened all of these trust framework organizations so that regardless of which identity provider they get certified with in terms of these trust frameworks, there is an equivalency across the trust frameworks to trust the actual identity credential that's been established. So if you're a relying party, as long as you use an identity provider that's been certified by one of these trust framework organizations, you can have trust that that credential was identity proofed in a manner that's consistent with the standards. And so you're going to see this over the next few years take hold at scale in healthcare. And we're going to move towards person-centric digital credentials rather than having organizational specific credentials moving forward. And we look forward to working with all of you on what that means in terms of how we establish trust. Final slide, we'll get to Q&A, Lynda, is this just gives you an action plan for the organizations. We've talked about many of these, but separating your IAM service from your backend, that's super important for identity. Strengthening your authentication protocols using the W3C standards that we had mentioned earlier. Supporting these identity-proof credentials. Mobile driver's licenses are live or in pilot in 14 states in the country right now, and so this is something in production today that's being used outside of healthcare that we could actually use. AMVA is an organization that actually has an API to validate that someone's driver's license is actually real. And they will you can subscribe to that service and find a way to actually validate that someone's driver's license is authentic to be able to meet the IL2 standards. And then we're going to figure out ways to federate these identity-proof credentials. And we've developed a white paper and this draft federated trust agreement that we publish later this year to get the industry feedback on it. So with that, Lynda, let's open it up to questions.
Yeah, great. Thanks so much. So the first one I've got here, Ryan, is, and again, either of us can answer it, please clarify if a provider sends a fax to the payer in support of a prior auth request, how will the payer provide this clinical information to the consumer? So my interpretation is because it's not structured digital information that they do not have to do that based on CMS recent ruling.
Yes, that's right. That is right, and it's only and I've been trying to get this link sent to all of you. I'm having a tough time, but we'll get it out to the group afterwards. But again, on our Confluence page, you'll see the CMS patient access API questions and answers from CMS. You'll see their actual written response. But if the data is actually in a fax or in a PDF, that clinical information does not need to get translated into an API for consumption by the individual patient-facing app. It's only the data that's actually in the systems today, the discrete information that's actually in the systems that can be mapped to USCDI, which, by the way, includes claims data. There's obviously clinical claims data, diagnosis procedures, other words that could be mapped to USCDI. Absolutely.
So you can't say this because you're a neutral convener, but certainly one of the things, this goes back to one of your previous points about sort of, there are still a lot of app vendors out there, still quite a few, even though they're not thousands, it's still. We are suggesting that payers go to your website, look at those various vendors, maybe check them out, the ones that have attested to your code of conduct, test them out, check them out, and maybe come up with a set that they want to at least have as recommended to their members. Now, again, every member is different in terms of the types of goals and how they might want to use an app with their data, but we think that being proactive may be better than sort of waiting for the onslaught. And so that's just sort of guidance that I think is helpful for folks to try to prevent the front door from building up with app vendors, initially.
Yeah, I think that makes sense. I do want to clarify, I made the point earlier, but, a health plan can't prohibit an app who's following the guidelines from connecting. But to your point, a health plan could promote a specific set of apps, and certainly linking to our website, the My Health application site, any of those apps would be doing it. I would also say it would be great. I would also say, some of those apps have different business models, right? So some of them are free to the consumer and could be freely provided on the website. Others have more of a B2B2C model where they'll partner with you as a payer, and you'll pay for those licensing agreements, and they'll give the app available to your membership for free. But that also allows your individual members to then aggregate their data from any payer provider in the country. So you'll have to talk to the individual apps themselves about what their models are, so you have a better understanding about that. But again, it's an opportunity, like you said, to promote folks that are doing things that are consistent with how the payer would like to interact with their individual user, which there's all kinds of use cases that are being solved for with these apps.
Yeah. So another question, and this was another one of those tough questions to you, Ryan, but there's this whole issue of, you delegate some of your business processes, so you may have a carve-out, that provides you with a feed, batch once a week or whatever for their claims and information. Sort of how does the one-day rule apply, the 24 business hours, apply to those scenarios? It's from when you get that information, not from when they adjudicate it. Is that your understanding as well?
Yeah, well, that's a tricky one. So CMS answered that question. The answer to that question is on that Confluence page, Lynda, so we should link people to it.
Okay.
I'm going to paraphrase their answer, which is always a danger, right? But they view this as 24 hours from the time that the claim was adjudicated. The immediate question that we get is, does that mean post-adjudication pre-check right, or does that mean post-adjudication post-check right? And we have advocated for post-check right, for obvious reasons, because the adjudication process isn't completed between those other two steps. And to your point, if third-party administrators are doing that, that becomes a little bit more difficult. Third parties that are doing that on their behalf. But I guess, Lynda, I know this anyway. I'm not obviously a lawyer per se, but I wouldn't get caught up if we're missing the window by a couple of hours per se, right? Like this is the intent of this is to provide the information. CMS feels the same way. This is the intent. I don't want to put words in their mouth. I apologize, but the intent of this is to provide this information in nearly as real time as we can. We recognize that, especially for payers, they're not necessarily used to they're used to working in a batch environment, not in a real time environment. And so, get it to the individual apps themselves, within 24 hours of it being adjudicated, and look at the guidance that you saw, in the Q&A section on the Confluence page for more information about that. But I wouldn't necessarily get kind of hung up on, if you miss the window by a few hours, et cetera. I will say, we as an industry are just moving to more real-time exchange of information. So this is really kind of a rethinking of all of the relationships you have and all of the different ways in which information is being disseminated today, because, when we have these FHIR API endpoints, anyone can get access to any of the information at any time based on the business policies that are associated with the exchange of that data. So it's going to be a lot faster than what we've experienced in the past. But we also, CMS has been pretty clear in the public comments. They don't want to make this, unduly a huge undue burden on the industry any more than what's currently been.
No, of course not. And again, I think your point about the, as fast as possible, but with the goal of looking at your internal business processes to see how you can sort of speed those up and change your business model so that not everything is in this batch mode, right? Because once we start liberating data through APIs, that provides just whole different opportunities for how we share information.
Yeah. But, if typical payer, they adjudicate their systems in a batch mode overnight, that information is then available in their systems. It should be made available, within 24 hours to a third-party app. That's just a kind of a logical flow. CMS obviously is not an expert in claims adjudication processes like everybody here on this call is. So it's a matter of kind of doing that in a way that's consistent.
Yep. So sort of the last question that I'm going to field is the benefit of sort of having that clean data, and I think we talked about it earlier in the call, but there's also the data provenance issue, right? So if the data that comes through from a clinical partner of yours, might not be accurate, right? It may just be something you as a payer received and it gets passed through the third-party app. So again, I think making sure and working with having that provenance information available so that there is a way that either the member or if the member calls member services can at least trace it back to say, you really should be talking to this provider if this information doesn't look right to you. Because I think CMS was patently clear that, as a payer you can't necessarily be accountable, but you at least can help provide the breadcrumbs and point the member back in the right direction to help them remediate that.
Correct. And I think what you're going to see just from a data cleansing perspective is not only the data coming out of the system's claims and provider, but then the data going back into these third-party apps. Are they getting displayed in a manner that's consistent with how the data was meant to be sent? And this is going to be a work in progress in 2021, right? How do the different data holders start to work with the app companies to say, actually that's not what that means. That's an adjustment, so it shouldn't be there. I mean, it's going to be an interesting road because we've now expanded the amount of companies that actually have information.
Well, we are at the top of the hour, so I want to thank everyone who joined us today. Again, if you've got some additional calls, I think that questions, they do get captured. We can try to follow up after the fact, but Ryan, as always, a pleasure, and thank you so much for joining me today. This was just extremely helpful, and please, again, there are resources on the CARIN website. There are resources on the Da Vinci website. Follow them, read them, keep up to date, because both of those groups as accelerators are in constant communication with CMS, trying to provide the community with that best information.
Thanks, Lynda.
Thank you, Lynda, and thank you all for attending this Fierce Healthcare webinar and for submitting so many great questions. Once again, thank you to Lynda and Ryan for participating, and I would like to thank InterSystems for presenting today's webinar. And remember, this webinar has been recorded. You will be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining. We look forward to seeing you at future events.